to enlighten us with some of the concepts that you think we need to address in dealing with delirium in patients in the ICU.
Sure, I'd be glad to answer that, and thank you for having me this evening. So with delirium, we have to really concentrate on our non-pharmacologic aspects rather than giving the patient more medications, because perhaps the medications we're giving them are actually causing them to have ICU delirium. So some of the things I would recommend doing is, what if the patient is awake and able to interact with you, is making sure, do they have their glasses? Have a family member bring those in from home. Or if they're an elderly patient, do they have their hearing aids? Are there pictures of family members in the room? Since they can't visit, you know, maybe there's that that they can look over and remind them of some happy times. Also during the day, making sure that the lights are on, the TV's on, the window shade is open to get in the sunshine. If the patient can sit up in a chair or in the chair position in the bed, trying to get them to do that. If they're able to work with physical therapy, that is good too. Now, if the delirium is part of a disease state, for example, if the patient has sundowning in addition to ICU delirium, that may be a little more difficult to manage, and we may use some atypical antipsychotics. But trying to also think about minimizing noises at night, not disturbing the patient at night when they should be sleeping. So bathing a patient at 3 in the morning may not be appropriate in some ICUs. And when a patient is also coming off sedation, you know, trying to wean them slowly, not only for ventilator purposes, but also, you know, trying to make sure that they're not overcompensating because we're weaning their sedation too quickly. So maybe if they're on fentanyl and Versed drips because we had them paralyzed and prone, transitioning them to lighter Rascals and even switching them off of those and onto dexmedetomidine perhaps, in order to make sure they stay calm, but also give them time to metabolize all of that analgesic and sedative out before really transitioning them off onto nothing. So again, a lot of non-pharmacological things we can do to help prevent delirium and then also work through that as well.